Good evening, my dear colleagues and friends from around the world. And for some of you, good morning. My name is Zaf Nakwi. I'm a hand surgeon based in Manchester, and it's my privilege to be able to chair the first journal club of 2022. Now, we have two very interesting papers, which are particularly relevant due to the impact of the pandemic to our current practice across the world. Before we start with the presentation of papers, I'd like to introduce the panel to you all tonight. So our handling editor is Professor Jinbo Tang. It's a real privilege to have him on. He's based in Nantong, China, and I think the time there at the moment is just after 3 a.m. We have a panel of experts. We have Thomas Giesen from Lucerne in Switzerland, Professor Jason Wong from Manchester in the United Kingdom, Dr. Lisa Newington, who is a clinical and academic hand therapist based in London in the United Kingdom. And our authors, we have Dr. Chen from Nantong, also from Nantong in China. And we have Dr. Munz from Florence in Italy. And we have presenting our papers tonight, Miss Lily Lee from Wrightington in the United Kingdom. And a very special welcome to Dr. Anna Fazova from St. Petersburg in Russia. Welcome to all our panel and welcome to you at home. And I'd like to start proceedings by asking Miss Lily Lee to present the first paper, which is on flexor tendon rehabilitation.
Good evening, everyone. I have the pleasure of presenting tonight's first paper, which was published in February 2021, following revisions. Dr. Jing Chen and colleagues from Nantong in China published their work entitled Measurement of Finger Joint Motion After Flexor Tendon Repair, Smartphone Photography Compared with Traditional Goniometry. The authors start by explaining how functional outcomes after flexor tendon repair are measured, usually using measurements for active range of motion at the PIP and DIP joints. The gold standard technique is for the assessor to use a manual goniometer on the patient's injured finger in a face-to-face setting. In this paper, the authors highlight the problem that returning to clinic is often difficult and inconvenient for the patients, which results in higher numbers lost to follow-up and therefore reduces the accuracy of any research. The authors introduced a concept of using high-definition photography on modern smartphones as a proxy for face-to-face range of motion measurement. The paper is a retrospective review comparing range of motion measurements at the IP joints using smartphone camera technology versus traditional goniometer measurements. The study is a case series and represents level 4 evidence. Cohort demographics were well described and include 37 fingers in 33 patients. A mix of index, middle, ring, and little fingers were studied, as well as a spread of zone 1 to 3 injuries, with zone 2 by far the commonest. The mean age was 37 years, and males outnumbered females. Inclusion criteria was a diagnosis of a complete FDP laceration. The repair technique was the same for all, the 6-strand M-Tang method, followed by early active rehabilitation. Patients under 16 years were excluded, as were phalangeal fractures and any injury with marked palmar soft tissue defects. Concomitant digital nerve or digital vessel injury was not excluded. Patients were followed up for a mean of 19 months, with a range extending up to 39 months. These images here are taken from the publication. In each case, a single surgeon performed the traditional goniometer measurements of active flexion and extension of the DIP and PIP joints. The same surgeon then took photographs with a Huawei smartphone of each injured finger with the forearm and hand in the mid-prone position for the index, middle, and ring fingers, and with the forearm and hand supinated for the little finger. The phone was held parallel to the long axis of the finger. Angles were then measured from the digital photographs using specialist analytical software called ImageJ, which is public domain open source software. These same measurements were then repeated by a therapist. The results are presented in 3 clear tables. Table 1, shown here, shows the functional outcome of the repairs according to the TAN criteria between goniometer readings on the left, smartphone readings by the surgeon in the middle column, and the therapist on the right, with negligible difference between them. Tables 2 and 3 show for manual versus smartphone measurements at the top and surgeon versus therapist measurements below, the mean differences in the 2 methods and the statistical analyses. The analyses that they used were, firstly, the significance level, and all values were well above a p-value of 0.05. Secondly, what the authors call the interclass correlation coefficient. We presume this is the intra-class correlation coefficient, which measures agreement between the 2 methods. And thirdly, the Pearson correlation coefficient, which measures correlation between 2 continuous variables. For both coefficients, the values approach 1, which signifies perfect correlation or perfect agreement. The authors also performed BlandAltman analyses, which is included in the supplementary materials section and which I have shown here. BlandAltman analysis is used to help researchers perceive phenomena such as bias in their data. The results from this study show that most of the data points lie within the 95% confidence intervals, which are the top and bottom horizontal lines in each graph, with the central line showing the mean. However, a few of the data points, namely the PIP and DIP extension deficits, do show some significant outliers. In summary, this study was a retrospective case series. The authors presented innovative practice where they employed simple modern technology to measure finger motion. They showed convincing evidence that smartphone measurements were as good as gold standard goniometer measurements and with strong inter-observer reliability between surgeon and therapist. Limitations they describe include lack of comparison between photography taken by the clinicians and those by the patient or by a relative, which would actually have the biggest and most useful effect, that of reducing the number of patients lost to follow-up by having patients send in post-operative photos from home rather than put through the inconvenience of traveling to the hospital. One query that I have with the authors is that they have not directly stated how or where the measurements were taken. We assume measurements were taken face-to-face based on the measurement technique described in the methods section. However, in the discussion, the authors state that almost half the patients in this study were evaluated in their own homes. Does this mean for the study that the clinicians travel to and perform the measurements in the patient's own homes? This surely negates the practicality of a virtual smartphone measurement and therefore the point of this innovation. I now hand over to the panel for discussion.
Thank you very much, Lily. Very well presented. Well done there. And in fact, based on your final statement, I'd like to go to Dr. Chen, if I may, and ask him regarding how measurements, how the photographs were taken. Were they in the clinic or at the patient's home? That's the first part. And the second thing is that I note that you started collecting this data pre-pandemic, if I'm correct in reading the paper. And I just wanted to know why you started to look into this. What was the driving force, Dr. Chen?
Yes, thank you. Thank you for your invitation. I'm honored to take part in this seminar on European hand surgery journal club. We have also heard of several such journal club similar in China. This type of journal club has been praised by many Chinese soldiers. We will continue to do. About this article, measurements with an handheld goniometer is the standard method in clinic. But we find this method requires patients to come to hospital. In our hospital, hand surgery department is the clinical center of our province. Many patients from many different cities. So most of them live far away, and it takes 2 or 3 hours or even longer to drive. So many patients will not come to hospital again after the operation for follow-up and examination. So we are hard to instruct them to exercise and hard to follow up. So with the development of social software and electronic technology, we can set up a group with patients with through WeChat. Almost everyone has a smartphone channel, so this is can be performed. They can send us some photos to send photos to us to guide them to we can better treat their recovery. So
and thank you, Dr. Chen. And in terms of this study, who was taking the photographs? Were you taking the photographs, or the patients, or the relatives?
Yes, we took photos. Yes.
So the doctor was taking the photos. Yeah. Okay.
Yeah.
Okay. And did you find any technical? Was it the same doctor taking all the pictures, or different doctors?
Yes, it's me.
It's you. You took them all. Okay, fine. Thank you for that. I'm going to go, if I may, to Dr. Newington, who's a hand therapist based in London. And Lisa, may I ask you, in terms of your thoughts, your initial thoughts on this paper and potential applications?
Thanks. Yeah, I thought this was a really interesting paper, and it shows a potential strategy to assist with clinical assessments during remote appointments, which we all know as globally we've had to adapt to these type of appointments with our patients, and there is a need for a sort of standardized, validated way of making these types of assessments. I think personally within our department, we moved to taking screenshots from video appointments and measuring them using a manual goniometer, and that was our way of adapting. But I think we need to collectively come together to look at some validation data and to see what type of process might work best for all of us, and we need something standardized in terms of research outcomes. I think one point that's important to consider is it's quite difficult to visualize the middle and ring fingers for the photographs. So in this paper, I think they were slightly positioned so that they could be captured, which means that it's not always going to be a true reflection of full composite flexion. So it's just something to think around the positioning and how we might be able to do that.
And in terms of the application to manage patients remotely, do you have any fears in terms of loss of patient contact? The other aspects of therapy besides the measurement of the range of motion.
Yeah, it's an interesting point. And I think for a lot of the trauma patients, we still need to be seeing them face to face initially, and it's helpful to build up a rapport with your patient before perhaps switching to virtual appointments for that type of assessment. But for other conditions, there are osteoarthritis or things that don't necessarily need lots of hands-on intervention. I think it's actually quite helpful for patients to be able to access appointments at convenient times and to not have to travel into a tertiary centre, which could be some distance to receive some of the care. And I think it's going to be a blend of offering what's available to patients, I think is going to be important.
Thank you. If I could go to Professor Wong. Jason, your thoughts on the paper and potential applications?
Yeah, it's always great to see papers coming out of Nantong and understanding more and more about what they do across there. The paper is highlighting a number of innovative approaches to looking at patient outcomes, and I think that's really the message I'm taking home, is that how can you empower patients to potentially record their own results and then have it validated and have it meaningful to look at your outcomes within your department. The technology is not new. I mean, ImageJ was invented back in the 1990s, and most software programs that take digital images can allow you to take angles. And so any application actually within the hospital will potentially allow you to generate this kind of data. The question is, how do you record it, and how do you record it well? And there's an opportunity to help kind of co-design the BSSH registry, which is going to be looking at flexor tendon outcomes at some stage, hopefully. At present, that's PROM-related data, but with a bit of nudging, there could be the potential for digital image capture. So,
thank you. And if I could go to you, Thomas, the National Health Service in the UK may not have the most robust IT system to cope with videos and images, and then there's issues around security and transfer of images. What's the situation like in Switzerland? And would you see, having read this paper, that you would adopt some of this in practice over there?
Yeah, thank you, first of all, for inviting me. Answering to your question, I think this paper comes into a bigger picture. There's telemedicine that nowadays is so actual because the pandemic, of course, and is forcing us to see the patient on distance with telematic systems. In Switzerland, we are developing, and we have already a system for telemedicine, and who developed it actually had to go a series of hurdles, and the same hurdles I can see also for measurements, telematics, and these hurdles are basically the confidentiality and the storage. If you put in the storage just the number of the degrees, or you're just storing the pictures, of course, and of course, how to use this data. If it's used for internal use and just to follow up the patient is one thing. If you're using this data to publish a paper, then the data must be validated. So I think this paper is opening or showing us where the road will probably go in the future. But I think there's still a lot of work to do to go and to have a distant evaluation and follow-up of the patient. And if I might say one more word about it, unfortunately, these systems nowadays with the pictures to just measure the angles, and we don't have any feedbacks on, I don't know, how the scar is hard. If there is any neuropathic pain in these fingers, you might have a nerve cut, and also the pain, and how stiff or supple is this finger. And so the way to go for this paper is basically showing up a road and very hard road to walk, and probably pioneering something.
Thank you, Thomas. And on that note, I'd like to come to Jimbo in terms of your approach to, what were your thoughts on when you first received this paper, and on what basis were you keen to have this published? And did you have any issues initially with the methodology and the scientific rigor of the paper based on the comments we've had?
So this paper, I think, as Thomas just said, opened a new way we could proceed to develop some new perspective on the functional evaluation after tendon repair. It is performed before pandemic, but it became more relevant in the pandemic period. So when I received that, I saw this could be a very good paper in this period of time to stimulate us for further research. In moving forward, there's a few questions need to be answered. First, to be practical, we need patient or patient relative to take the picture, not the doctor. That's in the discussion. Then training of the patient or patient relative is an important task. Of course, we can repeat multiple times until the doctor say, yes, this is a fine picture. But definitely it's not the doctor who will take the picture rather than the patient or relative. That's number one. Second is, for evaluation of function, you do not need to be so accurate to like 1 degree, 2 degree, that accuracy, because function of the finger does not depend on that 1 or 2 degree, rather than a slightly larger difference. So it also means when the patient or relative take a picture, you can allow some inaccuracy in relation to the function rather than exact number. So these are questions we need to answer in the future. Actually, Dr. Chen is still moving forward in that direction to address that in subsequent studies he's planning. I think this question will be the next few to be answered.
Thank you, Jimbo. So that brings us nicely to the end of this particular paper review. I'd like to thank again Dr. Chen for his efforts, and also Lily for presentation. So we're going to take a very short break. I'm going to play you a video, and then we're going to come back and discuss the second paper for this evening. So if I could have the video played. Fantastic, and that's a reminder that London is absolutely open for business. We hope to see you all in a few months' time. It's quite apt that we play the video tonight, because we've in the Journal Club we've truly achieved a global audience tonight. From China to Peru, we have hand surgeons and hand therapists from across the world joining us tonight. So on that note, I'd like to go to the next paper, and it's a privilege to invite Anna Fazova from St. Petersburg in Russia, who's a young hand surgeon there. Anna, привет. I hope you're doing well, and welcome to everyone in St. Petersburg. If you could present the next paper, please.
Good evening. I'm glad to present you an article which was published by Dr. Giovanni and his orthopedic colleges from Italy on 24 of May 2021. This work on up to 5-week delay in primary repair of zone 2 flexor tendon injuries, outcomes and complications. The authors of the article want to understand whether the delay in the initially repair in tendon in zone 2 is a determining factor of the final result. The main conclusion is surgical technique and postoperative protocol are more important than timing. It is necessary the operation to be performed by an experienced surgeon who specializes in hand surgery. Also, the correct postoperative management included early active rehabilitation at the gradual increasing is vital. The numbers of cases with not control group was studied and represent with 4 levels of evidence. The slide involved 28 patients and 31 fingers. The mean it was 24 years. All patients had damage injuries of flexor tendon in zone 2. All patients underwent delay repair of period of 2 to 37 days. The study didn't include patients with tendon injuries, the osseous areas, fractures bones, and amputations or subamputations, and patients with rheumatoid arthritis. After the operation, patients were under the supervision of the surgical and had checkups after 2, 4, and 6 weeks, and after 3 months. The slide shows the surgical process. While repair in tendon, the surgical incision included the original wound site. Both were initially spared as much as possible. After the stumps were identified, the adhesions between the tendon and the digital shade were released using small bilateral elevators. Tendon was repaired with 4 or 3 fiber using a tongue technique and the double tugi method. This was secure, but 5 nylon running suture. In the postoperative period, all the patients were given a cotton padded dorsal splint. The splint has the MP joint flexor and 30-40 degree, but fingers covered that goes were free to move. Early mobilization was promoted for all patients. Outcomes were measured at the last follow-up using the Bugranka and tongue criteria. The Bugranka method considers the total active motion to the sum of MP, PIP, and DIP joints for fingers and of the tongue IP joints. The tongue criteria considers the total active motion of PIP and DIP joints for fingers and IP joints for thumb. This slide shows a table with the results. Across the tongue criteria, the results were excellent in 30, good in 12, for in 1, poor in none, and failure in 5 cases. According to the Boomerang criteria, the results were among them the same. After surgical treatment for complications, 3 out of the 5 digits showed improvement. The final outcomes excellent, good, 27 of 31 fingers, 87%. The authors highlight the following complications: rupture, adhesions limiting the active range of motion, bolstering, superficial or deep infection, complex regional pain syndrome, and trigger finger or tenosynovitis and wound dehiscence. So this study is series of the cases without a control group. Unfortunately, the article doesn't tell if authors recommend a passive flow motion until the time of surgery to reduce the risk of contracture. The authors present a high percentage of good and excellent results according to the tongue and Boomerang criteria because they are preferable for this type of damage. Bolstering is mentioned in the text, but didn't appear as a complication in the final table. The article identify incision and exclusion groups. Thank you for the attention.
Anna, thank you very much for that presentation. As we did before, I'd like to start by going to our author, Giovanni. Giovanni, congratulations on the paper and welcome to the Journal Club. You mentioned that it was due to the pandemic that the repairs for flexor tendons, the time limits were stretched, but in your unit or the unit where this was written up, was there a casual approach to the time to flexor tendon repair, or was this something completely brought about by the pandemic?
Well, we used to perform DLR repair before pandemic, but the average time was between 7 to 10 days. And so the pandemic has increased the average at about 2 weeks. The delay, the primary delay repair for our unit, was not a choice, but a condition.
Okay.
This was due to emergency room delay and access to operating room delay. I think the possibility of active mobilization after surgery may have reduced the adhesion. But anyway, in this group of patients, we reported 4 complications, 4 failures for adhesion that are not so little. That adhesion are not so much. The meaning of the study is that it's not a tragedy to delay so much a primary repair, that you can achieve good results.
Okay, thank you, Giovanni. I think we'll get into the specifics of the paper because I'm sure some of the experts will want to question you on that. But certainly the results or the message of the paper is something that is potentially a source of controversy, and I'm sure will cause some great debate. So in fact, I'll start with Thomas on this occasion. Thomas, before you, I'd like you to critique the paper in terms of your view on the study, but I want to quote to you what Greens says about the outcome of flexor tendon repair. Greens operative hand surgery, it says the expected outcome after flexor tendon repair is variable and depends on the nature of the injury, the timing of the repair, the method of the repair, and the ability of the patient to participate in the program post-operatively. So we've always been taught clearly that time when it comes to repair of flexor tendons is crucial.
Yeah, thank you. So, I would like to answer in this way. First, regarding your precise question about the variables that come into the outcome of flexor tendon injuries are really many. Surgeon experience, technique, and there are biological variables, pliable skin, not pliable, kind of trauma, diabetes. There are so many variables in it. And time is one of these variables. I think that this paper is making two statements. One is a very clear one, and one is a kind of a hidden one, is a hidden message. The clear one to me is something that was already published in 1968 from McFarlane. It was published in 11 cases repaired after 1 year. And of course, this paper is telling us that probably if we have a delayed repair, we shouldn't go straight forward for a transfer, tendon transfer or secondary surgery. Wow. But we might still consider a primary surgery, probably adding to the repair also a lengthening, for example. But this paper is telling us that a delayed repair is still possible. We don't know how much timing is, this paper is telling us this 3 weeks cutoff might not be that important or that true. And this is the clear message. Then to me, there's a hidden message in this paper. And if you look at the bad result of or the failures, they all happen between day 10 and day 19. And this is kind of interesting to me. I learned in the UK, actually, there's a kind of a wooden phase after an injury. And this paper likes telling us, or you repair straightforward, or you wait up to 1 month, and you might have a better result if you repair this later after 3 weeks. This, of course, is not demonstratable, but it's kind of a hint of a message of this paper, and that's why I think it's really open to a big discussion.
So this paper is convinced you? Does it reaffirm your practice, or is it going to change your practice?
This confirms my practice and is a kind of challenging a dogma, and by reporting what they've done, that's simple. They just reported what they've done, and they're challenging a dogma. So in my practice, I will keep on doing the same thing I was doing before, and this paper is supporting my practice. If I have a delayed repair, I inform the patient before going in that it might be possible to directly repair the tendon, probably adding to the repair also a lengthening procedure in order to lengthen the tendon, like a levier lengthening at the tendon muscular junction.
Thank you, Thomas. Jason, I'd like to bring you in, and I'm going to start with another quote for you. I'd like to quote to you the BSSH best practice guidelines for hand trauma on the BSSH website as we speak. which say as follows: flexor tendons need to be primarily repaired within 4 days. Many a medical legal report is written based around those time limits. So I want to ask you again in terms of the timing and the science, the science that we've had so far regarding timing, and also for you to critique the paper.
Well, thanks for that, Zaf. Yeah, so I mean, this was born out of the pandemic, and I congratulate Giovanni for the paper. We had this similar problem pre-pandemic in Manchester back in 2010, and it was then when we looked at our service before and after 7 days, and certainly we found a correlation between poorer outcomes if they were repaired after 7 days. And I suppose that has been one of the messages that we've had in our department, and certainly with some of the other evidence, we've began to proliferate that message of early repairs is actually what's better for the patient for a number of reasons. I mean, it's not just about outcomes. It's about providing the patient with a service. They've had an injury, they want to recover, they want to get back to work as soon as they can. So it's the right thing to do to repair a tendon as soon as possible. However, there are exceptions, and I suppose this situation highlights an exception where the service isn't running as well as it can do, and you have pressures and you don't repair as quickly as you'd want to. The interesting thing for me about this paper is the kind of what it might hint to with regards to the science, and we've seen this in lower limb papers as well. In early injury, if you repair something straight away, you kind of get out of that phase where you're operating in an inflamed environment. And suppose, depending on the mechanism of injury, you might have a very inflamed environment that will keep on becoming inflamed over the next 5 days to a week. And I suppose operating in that environment, all the surgeons out there know that if you try to suture tendon 10 days down the line, it tends to melt in your hand. So there's something going on biologically that doesn't favor repairing in a delayed fashion. But there comes a point when that healing is beyond the inflamed phase. So 3 weeks, 4 weeks after the injury, it's actually far less inflamed. The edema settles down, and this has been highlighted by Jim Bo's work. And actually operating in a non-inflamed environment probably gives you quite a safe environment to operate in. So what we're seeing here is the rules that have been born out of observations missing out on surgery within the first week, but within 2 to 3 weeks. And then we're beyond the 3 weeks, and this is the kind of same as Godiva's papers, that beyond 3 weeks, actually the outcomes are fairly similar. And I suppose it's being aware that operating in an inflamed environment is not going to be good for your outcomes, because you're going to have swelling after the surgery, you're going to have impacting glide, and you're going to have an increased risk of rupture and adhesions. So that's my interpretation of the paper. Obviously, the work that we did in the past was correlation and not causation. I think that, if anything, it highlights that there's an impetus to start a research project on this. In fact, it would be a great national project to take on. Sorry.
Thank you, Jason. So in terms of the tendon biology at the ends of the tendon, which have been lacerated at 3 weeks, what this paper is suggesting is that the thought process about bad biology having an impact on tendon healing is blowing that out of the water. And what about retraction of tendons? Where are these vinculae? Where have the vincula gone? Where are the collapsed pulleys? How are we accounting for all of this in a direct repair 5 weeks down the line? What's going on?
So every injury is different. Okay, so every injury is completely different. You might get damage to the vincula, you might not get damage to the vincula. You might get shrinking of the pulleys, or you might have your tendons stuck within the pulleys and therefore they don't shrink at all. I think I think there will be cases that you do at a late stage, which will give you a very good outcome. I mean, the latest I've ever repaired a flexor tendon is 10 years down the line. I repaired primarily because the tendon was stuck in the pulley. So it was fairly easy to retract and repair under wide awake. Now, you can't plan for that. You can't plan for that. That's just the luck of the draw. I suppose how do you optimize your chances of a good repair? Well, I think it's about understanding the tissue handling in an inflamed environment and a non-inflamed environment, and trying to work your way around that. And if there was a tool that allowed you, augmented reality, that told you that it's an inflamed environment, don't repair today, that'd be the way forward.
Thank you, Jason. So, Dr. Newington, if I could bring you in as our expert therapist. You're the fly on the wall. You receive all the different surgeons' tendons. You and your colleagues. Your secret's safe with us. You can share with us really what practically do the therapists believe are the most important factors, and is it surgical experience? Is it prehabilitation prior to the operation? And what's your experience been on delayed repairs?
That's a really interesting question. Thank you. I suppose the best thing is knowing that the tendon is robustly repaired, that there was no gapping, that you're confident that you can move it with an early active type protocol, and that it's a nice robust repair. Obviously, different patients present in different ways, and edema, it can be a limitation to movement, and it can cause extra restrictions in terms of movement. Also, there's sort of how the patient feels about their injury and what they're expecting in terms of rehab. So it's really helpful if there's some understanding discussed prior to surgery about what they might expect, type of splints they might receive, that they will be encouraged to move early, and that's all very helpful in just setting the scenes. With regards to delayed repairs, I think I've recently done a review of the UK sort of treatment guidelines, and often there was a note with repairs after 7 to 10 days that it was advisable to discuss with the individual surgeon, so whether there might be any different rehab expected. And I think that's a common view. I think as hand therapists, again, maybe fitting with the BSSH guidelines about the 4-day repair, we're always a little bit cautious about those delayed repairs. And I think the caution stems from understanding the surgical repair. Was it as robust as a normal repair? Is it slightly tighter than normal? Did a lot have to be trimmed back to be able to make that repair? And so it was interesting for me with this study that the rehab protocol just seemed to be reasonably standard. So there wasn't any additional precautions regarding their normal rehab protocol that they would use. I think there was a question in the Q&A about the splint was made out of plaster of Paris. Is that normal? But I think the patients were moving, so it was, to me, that seemed similar to a normal early active protocol. It's just the splint was made out of a slightly different material at the beginning and then moved to a thermoplastic splint, but they were still exercising. So yeah, I think it fits a bit with the discussion that went ahead at the Berlin IFSHT Congress around flexor tendons, and perhaps we should be looking more at how the individual presents and their sort of clinical needs in terms of the rehab, rather than being based on, okay, this was a delayed repair, we must rehab it this way.
Okay, thank you. And can I come to you, Jinbo, again, as handling editor for this paper? What did you like about the paper, and did you have any specific issues with the paper in terms of the methodology, or any concerns, particularly in view of the message this is giving, this paper?
Thank you. So I will first comment on the paper itself, then I will view something about the comment I have just heard from the panelist. First, about paper. This paper come to me, I like it because it presents data from the patient who has been repaired from that different time period. It's not particularly striking me 5 weeks or 4 weeks, that delay, that's not. I just want to this be published to show this is the same or similar, no matter how delayed within a few weeks. And in editing this paper, I insist also to present the data of failed patient in a table. That's the quite common way I have been doing. And I trust the editor board to do that, because this gives the reader room to interpret and analyze. I'm so happy to see Thomas have get extra information from that table, because those are very important. Author may miss that, editor may miss that the reader will read that and get extra important information. So it's the key to present those failure cases in a table very clearly for the succeeding investigator to read it carefully. So that's the purpose of presenting and editing this paper. In terms of the timing of the repair, I see no rigid limitation of setting any days. In the Eastern country, China, Japan, there's no limitation. Actually, only today I heard BSH has a rigid rule of 4 days, which I never heard of in China or in Japan, in Hong Kong, Singapore. No, there shouldn't be a very rigid day. No evidence support that. I repair this tendons up to 5-6 weeks. I remember the very latest 5-6 months, and then recovered, because once you can get direct repair, you go through quite similar early active motion with a little bit of care, not too much stretching, extending the finger. It will recover. Sometimes take a longer time. So there's no any reason to say we will not repair that because of delay.
Can I interrupt, Jimbo?
Yes,
for
please.
All the trainees, and there's many trainees who are listening tonight, are there any technical considerations specifically, because this is going to be for many trainees, we're challenging the dogma that we understand here anyway in the UK, specific to a delayed primary repair. So, can you talk to us about, for example, collapsed pulleys, for example, or scarred tendon? Is that not what you see?
Of course, the patient who come to me or my colleague after 3 or 4 weeks is much less than those come early. Within 2 weeks, I have no any problem to treat those patients similarly as the primary repair. Will not see any pulley collapse. After 3 weeks, usually we'll see the pulley collapse. In that case, you need to excise a part of A2 pulley rather than just vent that. And with a small ring of the A2 pulley retaining, that will prevent bone straining. And if the cut is at the A4 pulley area, you have to vent the A2 pulley entirely. Thomas also showed us you can vent A4 together with A3. So that's even widen the possibility you'll get rid of any obstacles to get the tendon glide in that area. Without those kind of considerations, collateral tendon and venting the pulley, you usually do not need to worry about the tendon will not go through or not being repaired with sufficient tension or strength. Of course, you need to do a extension flexion test after repair. That's a technical point. Ensure there's no gapping and no resistance from the pulley to the repaired tendon. That's the key. Extension flexion test.
Thank you for that. So I've got lots of questions coming in from our audience. I will try and some of them have been covered already. So one question is, when do we say to a patient it's too late to repair? I'm imagining from what I'm hearing from you all that there's no end limit. Has anyone got an end? Any of the experts got an end point? I think Jason spoke about someone at 10 years. Thomas, you also have repaired late as well. So I think you've already answered that. So I guess another question is, would the panel do BlandAltman for delayed repair? Is there any reason why you wouldn't do BlandAltman for delayed repairs?
I think Wellance is a great tool for you to assess the patient without too much trauma. It's, you know, you can talk to the patient and you can tell them what you find. That's the benefit of it. So if you can't identify the tendon ends, you can say, look, I've tried it. Do you mind if I convert to this operation? So the patient buys into the decision-making process, and that's always a good thing, I think. It requires you to be perfectly comfortable with Wellance, of course.
Okay, Thomas, question for you from the audience. Can you explain more the lengthening procedure and how and when to do it?
Okay. Basically, okay, I try to be short. So basically, by doing a delayed repair, you might be ready for everything. First, I will answer about the Valant. Is it possible? But in case you planning to do a lengthening, you have to be ready to put the Valant in the forearm, because the lengthening will be there. So I personally prefer in this case probably to have a plexus. But yeah, this is one thing. Second, by exploring the finger, and Professor Tang already said, if you're ready to be brave to sacrifice some pulleys, we know from literature, and we saw already from the last literature, that basically the A4 is expendable. You can cut it basically. That's kind of challenging dogma too. And once you've done this, because the tendon is already cut from a while, is normally stuck under the A2. The A2 is normally okay. So you might be ready. The E3, we know already from the literature that you might not consider it. So you can attach your tendon by leaving only one A1 and A2, and we have got cases saying that this is possible. You might be ready to remove partially or completely the FDS. And this is another dogma that might be challenged, still discussed. And then going to the lengthening is done in the forearm. With the longitudinal, I do with a longitudinal curve incision in between the middle and the distal third of the forearm, and by going on the FTP group and just isolating the myotendinous junction. And yeah, you come a little bit with the practice of basically severing the tendon exactly 90 degrees with the axis of the forearm, but at the myotendinous junction. And then at this point, what I do, I just look at the cascade, and this is giving me the right tension. And you might be required to do this probably 2 times to do 2 lengthening. I normally start not very close to the tendon, so I start exactly in the middle, and then if I need, I go a little bit more proximal to go some more lengthening. This how do I do it, and the tension is given to me basically by the cascade. I realized once I was giving a little bit more tension because I was scared to lose tension with time, but I realized my bad results were sometimes because too much tension. So I just achieve a normal tension, and I can straight the finger with the test without problem.
Thank you. I think we've covered most comments. So there's another comment. My question is, when do the panel advise the patient that it's highly possible that we would need a tendon graft because of delay? Does anyone want to answer that?
So when I see patient comes 4 or 5 weeks later, I would say to patient, if I cannot pull 2 ends together, I'll just give up. After a few months, come back again, I do a tendon graft. If the patient come to me, that's very rare, a few cases only. After a few months, I will say, I will do a tendon graft for you, but I will prepare to do a direct repair if I can find it, and then I can connect it together. I say there's a little bit shifted emphasis to the patient according to time, but I'm always open to 2 options.
Thank you, Lisa. There is a question about, from Ardashir, there's a question about stiffness and the role in functional outcome, no matter how delayed the tendon repair. Would you like to make some comments about the impact of stiffness of the joints around tendon repair?
Yeah, I mean, joint stiffness is something that you need to address super early with the rehab. So the passive flexion is not going to be detrimental to the tendon repair, so it keeps the joints supple. Obviously, the extension needs to be protected. Various ways to do that with various splints, various protocols. The new move to sort of relative motion flexion as well, which adds an additional ability to extend the IPJs a little bit more. But I think in terms of keeping the joints supple, it's really honing in on patients the importance of working on the passive flexibility into flexion as well as the active movement, and to do the passive as first as a warm-up almost, to just try and keep those joints supple and to get in there early with that.
Thank you. I think we're pretty much at time. We've just gone over the hour. I think if that's acceptable with the panel, we will call it there. I'd like to congratulate the authors, congratulate the presenters of the papers also, and thank the panel. We truly have had a global audience tonight. We've set a record. We've had well over 200 people tune in from around the world. And I'd like to invite guests to come back in future. We have this journal club on a Wednesday every 2 months, at the last Wednesday every 2 months. So please do keep coming back. I'd like to invite you all as well, remind you all to come to London in June, and we hope to see you all there in person. Congratulations again to all, and I would invite for the closing video to be played, and I hope to see you all in 2 months' time at the next Journal Club. Thank you.